Did you know that nearly 80% of women experience at least one symptom of menopause? Yet many feel unprepared to navigate this natural transition. Surprising, right? Despite the wealth of information available, many women still hold on to myths and misconceptions about hormone replacement therapy that can affect their quality of life. For instance, a recent survey revealed that a significant number of women believe that HRT is dangerous. In fact, it can be a powerful ally in managing menopause symptoms. Welcome back to another episode of the Gayu Lewis Podcast, where we explore crucial conversations around health, wellness, and empowerment. I'm your host, Gayu Lewis, a menopause wellness advocate dedicated to demystifying the menopause journey for women across everywhere. Today, I'm thrilled to welcome Dr. Hajra Adil, a UK-trained family medicine consultant with a special focus on women's health, particularly menopause. Dr. Hajra is a respected member of the British Menopause Society and the Faculty of Sexual Health. Her passion lies in educating women about pre- and post-reproductive health issues, striving to dispel the myths surrounding HRT and empower women with the knowledge they need to make informed decisions about their health. Dr. Hajra not only understands the medical aspects of menopause, but also emphasizes the importance of lifestyle medicine as an essential component of menopause care. No wonder we connected. In our conversation today, we'll explore what menopause really is, the benefits and risk of HRT, and how women can take charge of their health during this transformative journey. Get ready for an enlightening discussion that aims to empower women to ask the right questions and seek the guidance they deserve. Let's dive in. Dr. Hajra, I'm so happy to have you here today.
Thank you, Gayu, for having me here. Thank you for the lovely introduction. It's an absolute pleasure. Women's health and menopause is very close to my heart for various reasons, some personal. And I really, really appreciate and admire the work that so many people are doing in bringing menopause into conversation. I used to see so many women coming to see me feeling vulnerable, feeling lost, having so many issues surrounding the symptoms, surrounding their quality of life. So I think by creating these sort of safe spaces for them, by changing the narrative, we're really changing how they perceive menopause to be, and that all leads to, wellness and well-being. So yeah, thank you.
Dr. Hajra, the first question, can you explain what menopause is and what women can typically experience during this transition? What are some of the most common physical and emotional symptoms that, women feel?
So menopause, by definition, is basically when your periods stop. But I don't really like that definition that much because there's a lot more to it. So if we look at our sort of reproductive life and the menstrual cycle, what we're trying to do every month, or what our body's trying to do every month, is releasing an egg, and in order for a woman to get pregnant. So what's happening along the reproductive journey is we're born with around 1 to 2 million eggs, and that sort of reduces gradually. And by the time we reach menopause, we've got about 1,000 eggs. That's really important because that's related to the hormones, estrogen and progesterone, because they reduce at the same time. Menopause basically marks the end of reproductive life and fertility. And it's a gradual change. It's basically what we call a transition. So the phase actually begins with perimenopause, where the ovaries, so it affects ovarian function as well. So when ovarian function's a bit wonky, we're starting to get some of the symptoms of menopause. Our periods are a bit far apart, so the menstrual cycles are further apart. The periods can become lighter, heavier, painful. But alongside that, some other symptoms start to sort of creep up. For example, hot flushes, night sweats. They're called the vasomotor symptoms. Sleep disturbances, brain fog, difficulty concentrating, joint pains. A lot of women wake up with a lot of joint pain and stiffness, muscle aches, constant fatigue, and sometimes it's that sort of term we call tired all the time. So they could catch up on their sleep, or they could do various other things, but they're still tired, and nothing sort of explains why. So that's another symptom that they have. Weight gain. Then they get a lot of psychological symptoms as well, like mood swings, irritability, anxiety. And along with the anxiety, some women complain of palpitations, and that can be worrisome as well. Some women get low mood and depression, and that can be quite debilitating for them as well. So those are the sort of physical, psychological symptoms, and it sort of begins with the perimenopause and into the postmenopause. And for some women, the symptoms can go away. and they're fine. But for about 25% or 25 to 30% of women, the symptoms can remain. Now, some women, they might notice, okay, they've gone through the menopause journey, but then later on in their life, they get another bout of different kinds of symptoms, which can occur in the perimenopause as well. And they're called the urogenital symptoms. And they basically, we call it urogenital atrophy. In the US, it's called genitourinary syndrome of the menopause. But essentially, the symptoms are vaginal irritation, vaginal dryness, vaginal discharge, because the lactobacilli, the friendly bacteria around the vagina, basically gets disrupted, reduced. So women tend to get a lot of infections like urinary tract infections, thrush infections, bacterial vaginosis. And another kind of main issue which is hidden, women don't like to talk about it, is painful sex. So sexual intercourse becomes painful, and because of that, because they probably already have it, is sex drive reduces as well. And those issues are not discussed in a lot of medical consultations. So we really have to ask women about it. A lot of women think, that's it. If I'm in menopause, I can't have sex. It's not necessary, but we have to ask them, are you sure? Is it important for you? And let's talk about it. So those are the main symptoms. I'm sure I've missed lots out because we've got estrogen receptors all over our body. And that's why we get a whole plethora of symptoms occurring. Those are the menopausal symptoms. The list goes on.
Yeah, I was just going to say, you listed everything from A to Z. And there was nothing that was probably missing there.
I'm pretty sure I've missed some. There's one interesting symptom which actually I started having, which is formication, which is when you get these sort of funny insects crawling over you and restless legs. That's an unusual symptom. Women won't be able to understand and link it. So, weird and wonderful symptoms happen.
Recently, I heard about frozen shoulder being one of another symptom because of menopause.
Yeah.
It's pretty funny. I said, did you know? I'm like, no, I really did not know.
Exactly. So, and tinnitus is another one that a lot of women complain of. My mum had it.
Yeah, I'm saying A to Z, all the symptoms are there.
I know, exactly.
There is nothing that is gone.
Absolutely nothing. Yeah.
Poor women, for us.
No, we're going to get through it.
Yeah, we will. Totally. There are a lot of misconceptions, like I said, about menopause. Are there any biggest myths that you've encountered?
There's lots, absolutely loads. So the first one is women coming to see me, wondering what their symptoms are and kind of associating menopause with just the hot flushes and the night sweats. When I sort of introduce the conversation of menopause, they'll be like, no, I can't be in menopause. I'm not getting the hot flushes. I'm not getting the night sweats. So then you've got to bring that conversation back in and say, well, actually, menopause can cause a lot of different symptoms. And obviously, we have to look at anything else going on and base it, according to all the other symptoms they're getting, what their menstrual cycle is, their age. But that's one misconception, that menopause is just about hot flushes and night sweats and everything else needs to be investigated or dealt with differently.
Do you feel that, a lot of women don't want to accept that they're aging? Is it one of another myth that you would think that people saying that, oh, I'm too young. Mm-hmm. It can only happen when I'm 50 and above, or it's,
Yeah, that's another big one.
Yeah.
So some women assume menopause to be when they reach 50 and their periods would have stopped. So they would be like, well, I'm still menstruating and I'm 47. I can't be in menopause. And then you have to explain, well, that's the perimenopause. Menopause just lasts a day and you would have had no periods for 12 months prior to that. So there's that sort of notion or thought process that they have that, menopause is when my periods stop or I reach 50. There is definitely an underlying feeling of difficulty embracing it, difficulty coming to terms with loss of fertility, even if they don't want to have children, or loss of femininity. So yes, that's a difficult part to get through, and I can completely understand that. But with these conversations, I think we would create a new normal for us.
Because I always feel that once you understand this is happening with you, if you do the right lifestyle changes at that time, your post is going to be a smoother,
absolutely,
transitions, rather than you hitting that post and you're like, oh, suddenly you're like, oh, where's my friendly estrogen? She's not there anymore.
Exactly.
And then you're like, kind of lost.
Yeah, and you've nailed it there with the lifestyle, because in the early stages, that's one of the only things we endorse. We would absolutely tell women to get their lifestyle on point, get your diet corrected, or better, or get the exercise in and get the right types of foods in and get the right types of exercises, especially like within my community, which is, amongst, Pakistanis and Indians, the Southeast Asian community. There is this kind of thought process of not really wanting to do much about it, let it happen naturally. I'm going to go through it anyway. And even if they don't want to take something exogenous, we should always be having that conversation with our mums, our aunts, whoever, about lifestyle. We should always be introducing the good sort of lifestyle hacks, the exercises that they should be doing. I mean, I was watching a video of a lady in India who was, I think, 70, and she was like lifting barbells, and amazing.
Yeah.
That's incredible. Like, I really wish my mum got to that point. So I'm really glad we're doing this now, and we need to get them kind of aware of the things they should be doing.
Dr. Hajra, you mentioned about speaking with your mom, your aunts. How much of their journey can you relate to your personal journey? Is their lifestyle was different? Is it our exposure to toxins that are increased in general? Can you really say that my journey is going to be similar, or can you take parts of that journey and say I could have these symptoms in?
Absolutely. I think there is obviously a genetic component anyway, but there's also that cultural vibe that you pick up from your mums and aunts. But you can always turn it into something positive. Yes, our mothers and our aunts, they had a different lifestyle at the time. They had different levels of support. A lot of them have been like the homemakers, the caretakers, they've looked after huge families and homes. So it's very different to our sort of nuclear setup that we have at the moment with our 2 kids, just me and my husband. And of course, the narrative has changed in terms of, the dynamics of how family structures are. Husbands are different now to what they were then. They provide a lot more support to their spouses. Children are different as well. And of course, that changes our mindset anyway. My journey has been different to my mum's because, well, personally, I've lived alone and I've been sort of self-sufficient. But I've sort of taken a lot of information being a doctor anyway, in terms of how I should be living, what I should be doing mentally, physically, socially, practically, so there's differences in that realm as well.
That's put a lot of pressure on you.
In what sense?
Like as a person, like are people judging you in terms of what you do and because they're trying to see what you do and kind of replicate in their own life? Does that put a little pressure on you as a person?
Absolutely. I mean, being a doctor is a pressured role anyway. You're always sort of looked upon, and I always like to tell my patients as well, like, I'm a human as well, and you have to always have that human touch with your patients. You have to, and I think I do more so hitting my 40s, because I've been through so many different changes from my own health journey to having children, facing illnesses that my children have faced, facing illnesses that my parents have faced. So I can really relate to so much more than when I was in my 20s and my 30s working as a doctor.
Doctor, I wanted to address the elephant in the room, which is HRT. There is so much of good and the bad around this. What exactly is this hormone replacement therapy, specifically when it comes to the menopause management? How does it work? What are the different types? If you could just help us understand that better.
Yeah, so hormone replacement therapy, as the name suggests, is replacing hormones. So when we're in menopause, we are deficient in the hormones estrogen and progesterone, and somewhat testosterone. But I'm not going to talk about testosterone too much today, because that's a whole topic on its own. But essentially, we're replacing or topping up the hormones estrogen and progesterone. So in the perimenopause, we're still having fluctuations in the hormone, so we're just topping it up ever so slightly. And when we're hitting the menopause, postmenopause, we're sort of keeping it within that range so that it controls our symptoms. It gives us that kind of better quality of life. So it's one of the most effective treatments for menopause. It improves relieves women of menopausal symptoms, improves quality of life. It's also got long-term health benefits, because menopause can affect our bones, our cardiovascular system. And for women who've had an early menopause, as in premature menopause, or what we call premature ovarian insufficiency, it can also help the cognitive dysfunction side of things and help reduce the risks of that.
Okay.
So there are lots of benefits of hormone replacement therapy, and basically it comes as 2 types. So it can sort of branch out into various different types. So the 2 types are the combined hormone replacement therapy, which is estrogen and progesterone, and estrogen only replacement therapy, or a preparation that only has the estradiol in it. Then we split it into body identical and synthetic. So majority of women nowadays are on the body identical hormone replacement therapy. So I'd like to just go back a little bit. Yeah. So many years ago, I think it's been about 20 years, hormone replacement therapy had a lot of bad press because of 2 major trials that were done, the Women's Health Initiative and the Million Women Study. So their results were very kind of worrisome for practitioners prescribing HRT and for women taking it. So we almost had a bit of a halt in women taking HRT, people prescribing it, and sadly a lot of women kind of lost out on that benefit. Many years later, we realized there was some discrepancies in those trials. Newer results came out from further trials, and also we've got newer products now. So at that time, synthetic products were used, and now we're using the more body identical products, which have a chemical structure that's similar to what our body produces. So they're basically essentially made out of the yam plant. They're gentler on our system. They've got a better safety profile. So those are the products that I also generally start women on. And then you've got different routes in which women take it. So you've got the transdermal route of mainly the body identical estradiol, which comes as patches, gel, spray, and then oral tablets are also body identical. And then you've got the micronized progesterone or utrogestin, which is the body identical progesterone. So those are kind of different ways we can take it. And you've got the synthetic versus body identical products. I think there are also other products which are, for example, the combined estrogen progesterone patches, but they have a synthetic progestogen in it. And then you've got the Mirena coil, which is an intrauterine device, which a lot of women love having, because it's also the HRT component. It provides the progestogenic effects and it helps protect the endometrium. And it also provides contraception. So the important thing to understand is, which we kind of gather from the history, is whether a woman's had a hysterectomy. Because women who've had a hysterectomy can take the estrogen-only preparation. But women who haven't had a hysterectomy and they've got a womb, we need to protect that womb from progesterone. So majority of the reasons why progesterone is given is for endometrial protection. And it's really important for women to understand that the progesterone, if they've got a womb, is very important. Otherwise, they're at risk of endometrial hyperplasia, because estrogen, if it's given on its own, can cause the lining of the womb to thicken, and then it can lead to endometrial cancer. So that's an important point we have to cover in our consultations.
How would you determine what sort of HRT is the right form for a particular woman?
So that really depends on what the background is, the medical background. That's really important. And also we can then determine whether HRT is safe for them. So obviously the main kind of questions we would be asking from that perspective would be whether they've got any cancers, particularly breast cancer, or any sort of particular types of ovarian cancers as well. We also need to look at their background kind of cardiovascular risk. And then the other thing we ask is about blood clots, whether they've had blood clots. We call that venous thromboembolism, or if they've got a family history of clotting disorders, because that will determine whether they are safe to take oral preparations, or if not, then they'll have to be on the transdermal preparations, because oral products transdermal products bypass the liver metabolism, and they're safe to take for women who've got high risk factors for clotting problems, including women who are overweight and have a high BMI as well. So these are the things we'll be looking at. And of course, their choice. Most women actually just want to go for the transdermal products and the micronized progesterone because they like to take something that's similar to what their body produces. They want to really minimize their risk, because also the micronized progesterone has a reduced risk of breast cancer as well. And we'll talk about that later. So it is down to choice as well. And I've noticed that many women are more keen on those products.
So if the transdermal is safer, why would people still opt for a synthetic? Because you're saying the synthetic comes with its own set of cautions surrounding it, which is potential blood clots or potential cancer. Why would someone take it?
Yeah. So at the moment, there are not so many women on the synthetic products, but the reasons why they might be on the synthetic products, so hardly any woman is now on synthetic estrogens. I think most of them are on estradiol, which is body identical, which is transdermal and oral. But when we're talking about synthetic products, we also have to include the progesterone. So sometimes women might not tolerate the micronized progesterone. Because it's a weaker progesterone, it sometimes causes bleeding issues in women. And so those women might need a stronger progestogen. So sometimes those women might, and we've sort of upped the dose and we've done all sorts of things, we'll either suggest that they take the Mirena coil, which is also synthetic, but it's more local release of the progestogen, or some other progestogen, as in a combined patch or a separate tablet. So that's the reason why. But majority of women are quite happy taking the body identical and not the synthetic products.
Can anybody who've had a history of breast cancer or has a family of cancer, can they never take HRT, or is there some solution for them?
Yeah. I was listening to a podcast the other day, and there was a breast surgeon who said most women who are afraid because they've got family members that have got breast cancer, they probably have like a second aunt who has it. So one of the things we do is kind of do a clear family, have a clear kind of family history of how many, immediate members or first degree members have breast cancer. So if that's the case, then I would probably send them to a geneticist to get tested for the BRCA1 and BRCA2 gene anyway. Okay. So we'll have to sort of explore that a little bit, how many members they've got, who and what side. So some will say, well, my aunt from my dad's side and my, other aunt from my mum's side. So we have to basically have a clear family history of who's got the breast cancer and then send them to a geneticist to see if they need testing for BRCA1 and BRCA2. The BRCA1 and BRCA2 genes, which really increases the risk of breast cancer quite tremendously above baseline for women. So that's the first thing we need to do. If they've got a distant member who's had breast cancer, then that's not really a strong family link. Okay. So those women can take HRT. They're not in the high risk category. But yes, if they've got lots of family members, first degree relatives, and they fit the criteria for even being seen by the geneticist for the BRCA1 and BRCA2 genes, or they've got the genes, then yes, we have to apply caution there, and they're probably going to be advised to not consider HRT. Having said that, I was listening to another podcast yesterday about a woman who had breast cancer. So interestingly, she took HRT and then got diagnosed with breast cancer. Okay. When she saw her GP and the lump was detected, she was immediately referred to the breast surgeon. The first question she asked was, am I going to stop my HRT? And the doctor said, well, at the moment, we don't have it confirmed, but it's up to you. Some women do stop if they've got a suspicious lump, and some women continue to take it. So she continued to take it. And when she got diagnosed with it, it was an aggressive cancer, and she had lots of treatment. She finished all the treatment, and during the podcast, one thing that really stuck with me was when she said, what I went through with my menopause was much worse than the treatment I had for breast cancer. Which was sepsis, which was hair loss, which was all the other side effects of the cancer treatment. So she said every kind of point of my breast cancer treatment journey, I would always double check and sort of take advice from my oncologist and really request whether I can continue taking the HRT, because that was really improving my quality of life, and that was really important for me. And that's what she said. That breast surgeon who I was listening to, he actually said, if I could, I would put all of my breast cancer survivor patients on HRT because of that quality of life that it gives them. So as clinicians, we have to not only focus on the quantity of life, the quality of life is really important. So we can't just be sort of increasing the quantity and then reducing their quality of life. Everything has to be sort of balanced. But I'm not saying that, all women with breast cancer should be on HRT. It really is an individual decision. It's an individual and shared decision made by the menopause specialist, the oncologist, the patient. And yes, a lot of the guidance suggests that women who've got high risk factors, who've got active breast cancer, who've got hormone dependent breast cancer, they're advised not to be on HRT. There are alternatives that they can take. But some women do choose to be on it, and we have to respect their choice, like that lady.
Yeah, very interesting. So talking about HRT, what age can I actually start taking HRT?
Right. So HRT can be taken when you feel there are some symptoms occurring. The perimenopause generally starts from sort of 4 to 5 years before the average age of menopause, but they're all average. I've had women in their mid to late 30s who feel they're in menopause or perimenopause. Of course, we call that premature menopause. There are women younger than that because they've had an induced menopause, because they might have had surgery, such as women who've got BRCA1 and BRCA2 genes. They would have preventative oophorectomy and mastectomy, so that they've had all their ovaries out because it's high risk of ovarian cancer, and they've had a mastectomy as well. So they are advised to be on what we call add-back HRT, to not only reduce the symptoms that they would be having, and the symptoms for these women come on really rapidly.
You can imagine,
because
it's like sudden.
The levels just plummet down. So, they would immediately feel the change. The quality of life is reduced, but also to reduce the long-term effects of that premature menopause, such as osteoporosis, cardiovascular disease, cognitive dysfunction as well. So those women would be strongly advised to be on it. But if that's not the case, there are other women who might have early menopause or perimenopause. They can start it. What I tend to do is, because there are no blood tests in the perimenopause phase that diagnose menopause. However, having said that, women who are younger than 40, we will still be doing blood tests, and some of them, they might have a raised FSH or low AMH, and those are the tests that we sometimes do. It's usually kind of the symptoms that would be guiding us. And then what we do is we give them a therapeutic trial of the HRT, tell them to come back in 3 months. And if they feel better, then, we know that probably was it. And they can continue taking it if they want.
Can I take HRT post-menopause?
So there are no arbitrary limits to how long you can take HRT for. The general advice is not to initiate HRT after the age of 60.
Okay.
That's not entirely post-menopause. So post-menopause can still be younger than 60. But in terms of continuing it, if women feel that they're much better, their symptoms are relieved, their quality of life is improved, then they can continue it. We do review them now and then. We'll always talk about the options of whether they would like to stop it, whether they'd like to try anything alternative, or, focus more on their lifestyle. But if they're like, nope, I want to continue taking it, I don't think I could live without it, then that's absolutely fine. I mean, I've had an 80-year-old lady who I was doing a medication review for, and I was asking her, so how do you feel about it? And I couldn't even complete my sentence, and she was like, don't you dare touch my HRT. So, there you have it. And at that point, you're thinking, well, the quality of life is really important.
I have a question, very funny in my head. So do we become dependent on I'm not saying it was there, that hormone was in our body. It's not that we're inducing something different and we become dependent on that. But do we kind of become dependent, and when that dosage starts reducing, or if you take it away, the symptoms hit you back? Do they hit you back really bad, or it's still manageable?
So research hasn't suggested that there's an immediate kind of rebound of symptoms. Some women can stop them, and they're fine. But for others, it does sort of rebound, that they can have rebound symptoms. So the general advice I would say is that if you are wishing to stop it, you can do it a bit slowly, just to kind of wean off slowly, and to kind of ease into life without HRT. But there isn't any kind of major dependency on it. Having said that, anecdotally, women may say that, no, I can't do without it. I stopped it and I feel awful, which probably means that, yes, they might need to continue it for a bit longer.
So, and you're saying that if I started it at an earlier age, say imagine 40 onwards, I can continue it post 60 as well, till I die? Or is there a certain point after which you're like, that's it, this is your last dose and be happy with it?
No, so as I said, there's no arbitrary limit to which they can take it if it's helping you. So what I advise post 60 is that women should be on the lowest effective dose if it's beneficial for them. So that's as simple as it gets. The benefits have to outweigh the risks, and they should be on the lowest effective dose. So if that's the case and it is helping them and they're on a safe dose, then that's fine. They can continue taking it. But yes, the benefits, for example, the cardiovascular benefit, might be lost post 60. So the advice is that if you are thinking of starting HRT, start it within the first 10 years of your menopause or before you're 60 to get that added cardiovascular benefit. And we call that the sort of window of opportunity.
So if somebody's had their uterus surgically removed, can they take HRT?
Of course, absolutely. So women have hysterectomies for various reasons, for fibroids, for heavy menstrual periods, for endometriosis. They can absolutely take HRT. For endometriosis, that's another topic that is a little bit complex because they basically might have to take estrogen and progesterone. So as I said, that women who've had a hysterectomy might be able to take estrogen only. But women who've had hysterectomy, we usually advise them to take the progesterone as well. And that's because the endometrial deposits could be elsewhere. And they could be reactivated, or sometimes not frequent, or, rather rare. You could have malignant transformation. So when it becomes cancerous, if you're just giving them the estrogen only. So that's why women who have endometriosis are more or less advised to be on both estrogen and progesterone. When we sort of think about estrogen and progesterone and we're sort of weighing up risks, we also have to take in the risks that HRT has. And we talked about blood clot risks, and I guess we talked about endometrial cancer. There's obviously the big risk, which we've discussed, is breast cancer. Now, the risk isn't big. It's actually a small increased risk of having breast cancer with combined estrogen and progesterone HRT. But again, we have to look at that risk in context with other risk factors. So, for example, being overweight or obese has a much higher risk, or drinking 2 or more units of alcohol per day has a higher risk. So we can't look at that risk. And that's a big fear that women have. They'll come in and they'll be like, HRT causes breast cancer. So we have to try and sort of bring that conversation with the other risk factors in that, included in that conversation, and say, well, I usually have my chart where I sort of explain what the background risk is, what estrogen and progesterone does, what estrogen only does in terms of the risk, in terms of increasing the risk above baseline, alcohol, obesity, or being overweight. So we have to look at everything in context, and also understand that the benefits are outweighing the risk for that individual. So looking into, for example, cardiovascular risk. I mean, cardiovascular disease actually has the largest mortality globally. So, we've got to balance things out a little bit. And I know breast cancer is the commonest cancer, affecting women today, but, it's not as simple as that. When we're talking about giving progesterone to women who've had their wombs out, for some, they may need to take both hormones. But we also have to balance that risk against that small risk of breast cancer that estrogen progesterone has as well. So it can get a little bit complex, but we try and make it as simple as we can and as safe as we can for all the women.
Is there any lifestyle habits of mine that could deter the effect of the HRT? Is there anything like, imagine smoking or drinking, that would affect the effectiveness of HRT?
Yes, absolutely. So smoking can actually, it won't reduce the effectiveness of HRT, but smoking actually causes a lot of women to have more night sweat, more hot flushes and sweats. So it causes a lot more of those vasomotor symptoms. And that also is the same with being overweight. So carrying extra weight can also enhance the vasomotor symptoms. So it won't necessarily affect HRT, but they can affect the symptoms. In terms of so I think I'm trying to understand the question. No,
I'm just saying, I was asking, does it, like, imagine if I'm on a medication and I counter it with something else. I'm just saying that, does any other lifestyle counter the effect of HRT? And you're saying, no, it doesn't counter the effect of HRT, but then it just can lead to some other symptoms.
Yes, exactly. So hopefully HRT should try and ameliorate those symptoms. But if you're thinking of like whether any of those lifestyle practices are contraindicated in terms of taking HRT, not particularly, because as we know that, for example, smoking, alcohol, well, firstly, HRT has cardiovascular benefit, but also HRT can help women who have resorted to, drinking alcohol. It can help women sort of come back to maybe reducing their alcohol intake. And in terms of things like smoking, we always have to counsel women and give them the relevant education in terms of, how they can stop smoking. So that would be a separate lifestyle, consultation anyway. So it all kind of fits together, but we do have to look at the separate components of their life and their sort of post-reproductive life as a whole.
What advice would you give to women who feel overwhelmed, by the options available to them regarding HRT?
There is a lot of information on social media. So many people are doing podcasts like us, and lots of Instagram videos. There's stuff online, and it can be really overwhelming. And I completely understand that. The best advice I would give is to speak to a healthcare provider who's aware of what menopause is, what the treatments are, has been up to date with the recent treatments, understands the evidence behind all the treatments, and will be able to explain all of that to you or to the woman clearly and effectively, so she can make her informed decision about it. So the best place to go would be a clinician or a healthcare provider who would be able to literally break it down and explain, what the different HRT options are, and also relate it to their own kind of lifestyle as well. And that also, and the sort of practical side of things is important. So, for example, if a woman has got a busy life and doesn't want to take a patch every 72 hours, and also component HRT can be tricky as well, because you're taking a patch every 72 hours and then you're taking the micronized progesterone every day. And imagine how confusing it can be. Women who are on a sequential regime, which is in the perimenopause phase, are advised to take that regime because they can have monthly bleeds. So that can be tricky because they have to take the progesterone, they have to take the estrogen only 2 weeks, or the first 2 weeks of the month or their menstrual cycle. Yeah. And then the latter 2 weeks, they will have to take the estrogen and progesterone. So it's 2 weeks on, 2 weeks off. Women who've got irregular cycles, they won't know. Yeah. So they have to literally go by a month and then sort of keep doing it that way. So it can get really tricky. So the doctor will be able to explore options, will be able to discuss what might be best for them, just so they're not sort of taking it in an unsafe way. They're not forgetting to take their progesterone, and they're compliant with it as well. So some women might prefer an everyday gel, some women might prefer a patch because they don't like the idea of rubbing a gel. So that doctor will be able to explore, or healthcare professional will be able to explore all of those options.
So don't ask ChatGPT or Google.
I don't. Yes, maybe not. I think it's always good to have. I'm sure ChatGPT is completely updated, I think, the ChatGPT 4, but I still am a bit traditional. I think you should speak to a person who is, an accredited specialist who understands HRT and menopause. And if you are looking for, online information, then my go-to usually are, because I'm from the UK, are British Menopause Society. That's excellent. They've got all the research behind it. And another one called patient.co.uk. And in the UK, I used to tell all my patients to read those two sources.
Finally, what message, do you want to convey to the women who are apprehensive about HRT and menopause in general?
Right. So I would advise women to really understand and listen to their body. Don't suffer in silence. Don't assume the symptoms are to do with being overworked or having lack of sleep. Do speak to a healthcare professional or speak to someone who might be able to signpost you to the right person. Really important to understand what menopause is, how it impacts your life. We're going to be living more than a third of our life in menopause. So it's really important to get the right information, the right facts about our lifestyle, about our diet, exercise, sleep, and HRT. Speak to a doctor about what HRT is, and they'll be able to explain to you the risks and the benefits, and they'll be able to do an assessment that's individualized to you and discuss it according to your needs and where you are in your menopause journey.
Doctor, where can the listeners connect with you and learn more about your work? And you already spoke about the resources that's available online, but how can they connect with you?
So I've just got an Instagram channel out. So you can find me on Instagram, Dr. Hajra Adil, Dr.Hajra.Adil. And on LinkedIn as well, you can find me. So I'll be doing a lot more. I'll share a lot more information on menopause and HRT on both the flat platforms, and hopefully I'll be able to create more videos about it. But at the moment, I'm still getting started.
You're doing a great job by educating all of us. Doctor, before we wrap, we've got the last segment of this podcast, which is called the 1%. 99% of our conversation is all around women, for women, educating women. But men are a part of our lives too. So what is your 1% advice to the men in our lives? How can they help or support women better?
Yes, men have a huge role to play because they can try and understand what women are going through, not just in menopause, but throughout their lives. Hormones don't just affect us when we reach menopause, they're affecting us during our monthly cycles. So hormones and us we will always be connected for pretty much ever. So men have to understand the changes we go through monthly in our menopause, during pregnancy, and how it impacts our quality of life. And they should be able to understand and support us in whatever way we want them to. So, if we want to be left alone, leave us alone. If we want to talk, then talk to us and listen to us.
Thank you so much, Dr. Hajra. I had an amazing time, and thank you for enlightening us on the whole bit on HRT so that we are more aware of what are the different options available and make informed decisions.
Thank you. And I really hope I've, explained HRT in a relevant way. I know it's very confusing. I know the whole space can be very overwhelming, but I hope I've done the job.
Thanks so much. I hope you guys had an amazing time listening and understanding about HRT. If you've got more questions, you can, of course, reach out to Dr. Hajra. You know her Instagram details. It will be in the YouTube links as well. And thanks again for tuning in. Until next time, menopause, why pause? Let's play.